All right, let's dive right into this explainer and see if we can solve the fascinating medical mystery of intestinal tuberculosis. When we hear the word TB, we almost universally think of lungs, right? Coughing, respiratory distress, the whole nine yards. But what happens when this notoriously tricky bacteria decides to set up shop in a completely unexpected place? Today, we are tracking a chronic infection that infiltrates the gut, perfectly masquerades as other major diseases, and requires a razor-sharp medical detective to actually catch. Here's our roadmap for today. We're going to cover the causes and spread, the underlying pathology, the symptoms and complications you need to look out for, how to investigate those clues, the great mimickers of this disease, and finally, the medical and surgical treatments. Okay, part one, causes and spread. Let's identify our culprit. So, to start our investigation, we need to understand exactly how Mycobacterium tuberculosis, which, again, is usually a lung pathogen, actually breaches the gastrointestinal tract in the first place. You might immediately think, oh, it's got to be hematogenous spread through the blood. And yeah, that definitely happens. But the absolute most common route? Autoinfection. The patient literally coughs up infected sputum from their lungs, swallows it, and delivers the bacteria directly into their own digestive system. It's wild. We also see some rare cases from drinking unpasteurized milk, which introduces a totally different strain, Mycobacterium bovis. Now, think about the entire digestive system. It's massive, from the stomach all the way down. So why on earth does this bacteria almost exclusively target one very specific anatomical spot?
Well, it's basically the perfect storm. The ileocecal region, right where the small intestine meets the large intestine, accounts for up to 90% of these cases. 90%! And there's a really good physiological reason for that. First, you've got relative stasis, meaning the flow slows way down. Second, there's increased fluid absorption, which effectively concentrates the bacilli. And crucially, there is a massive abundance of lymphoid tissue, called Peyer's patches. The bacteria literally seeks out this immune tissue and just sets up camp. Moving on to part two, pathology of intestinal TB. Let's look at the damage done.
Once the bacteria builds its stronghold in the intestinal walls, the infection can manifest in four very distinct ways. It's definitely not a one-trick pony. It might cause transverse ulcerative lesions that run a high risk of bleeding, or hypertrophic, mass-like lesions that look terrifyingly like cancer. It can even heal into thick, fibrotic tissue that ends up causing blockages. But the one you really need to watch out for is the ulcero-hypertrophic type. It's by far the most common presentation, and it brings a dangerous triple threat: strictures that narrow the bowel, ulcers that tear up the lining, and dense inflammatory masses. Section 3, symptoms and complications. How do we read the signs? Since our suspect leaves such a distinct trail of damage, we've got to recognize the clinical clues when a patient walks into the exam room. There's a classic high-yield triad for ileocecal TB: chronic abdominal pain, noticeable weight loss, and a palpable mass in the right lower quadrant, the right iliac fossa. Sure, they might also complain of night sweats or altered bowel habits, but that triad, that is the flashing red light every single medical detective needs to spot immediately. And if those initial signs are missed or ignored, well, the complications escalate incredibly fast. Because the gut wall becomes so inflamed and scarred, strictures start to form. This inevitably leads to intestinal obstruction, which, by the way, is the absolute most common reason these patients eventually end up in surgery. In even more severe cases, those ulcers can literally perforate right through the bowel wall or create abnormal, messy connections called fistulas. Part 4. Investigating the clues. It's time to open our diagnostic toolkit. To confirm our suspicions, we need hard evidence. Standard blood work might just point to some generic chronic disease. Anemia, maybe a raised ESR, but a contrast-enhanced CT scan of the abdomen, that is an absolute game changer. It's our best window into the gut. On this scan, you're hunting for asymmetric wall thickening in the ileocecal area and necrotic dying lymph nodes. And keep a sharp eye out for a pulled-up conical cecum, which happens when the severe inflammation structurally distorts the shape of the bowel. Now, imaging tells us there's a problem, but as the old medical saying goes, tissue is the issue. Let's look at the microscopic evidence from an endoscopy biopsy. Finding caseating granulomas, which are these nodules of immune cells with a sort of cheese-like necrotic center, along with Langerhans giant cells, is the definitive key to cracking this case. Here's a fascinating twist, though. You might not always spot the actual acid-fast bacilli on the slide. The bacteria are incredibly good at hiding, which makes the cellular damage itself our most reliable proof. Section 5, the great mimickers. Let's talk about the differential diagnosis. The plot really thickens here because intestinal TB almost never acts alone in our suspect lineup. It looks virtually identical to several other major GI diseases. If you find a mass in the right lower abdomen, you have to immediately rule out colon cancer, specifically carcinoma of the cecum and meiboma. Luckily, we can usually eliminate these using clinical context. Cancer typically hits older age groups, presents with a much harder mass and severe weight loss, and crucially, it won't budge a millimeter with TB medications. Amoeba, on the other hand, comes with a history of dysentery and clears up super fast when you hit it with the antibiotic metronidazole. But the ultimate showdown, that's between intestinal TB and Crohn's disease. The distinctions here are incredibly stark, and you absolutely have to memorize them. TB creates transverse ulcers that run around the bowel. Crohn's creates longitudinal ones that run along it. TB granulomas are caseating. Crohn's are non-caseating. TB is heavily localized in the ileocecal region, while Crohn's jumps around in those classic skip lesions. And while fistulas are rare in TB, they are everywhere in Crohn's. Why does this matter so much? Because if you mistake TB for Crohn's and hand that patient immune-suppressing drugs, you essentially turn off their body's defenses and let the TB multiply completely out of control. It is a massive clinical pitfall.
Finally, Section 6, Medical and Surgical Treatment. Let's resolve the case. Now that we've separated our true culprit from the imposters, it's time to actually heal the patient. And there is a golden rule of firsts in intestinal TB. Before a surgeon ever even thinks about picking up a scalpel, medical management is always, absolutely always, the first line of defense. We're talking about the exact same antitubercular therapy, or ATT, that we use to treat classic lung TB. This timeline maps out the patient's long but completely necessary journey to recovery. It kicks off with a really aggressive 2-month intensive phase using 4 powerful drugs to just hammer the bacterial load down. Then we transition into a 4 to 7 month maintenance phase utilizing just 2 drugs to completely wipe out any lingering bacille. All in all, you're looking at 6 to 9 solid months of continuous therapy to close the case. So you might be wondering, when does surgery actually come into play? Well, it's strictly reserved for when things go totally off the rails, or when medical therapy just can't fix the structural damage. We see this in 2 main scenarios. First, absolute emergencies. A stubborn bowel obstruction, a perforation leading to life-threatening peritonitis in the abdomen, or massive bleeding. Second, elective situations, like when we just can't be 100% certain if a mass is TB or cancer, or if a really tight stricture just won't resolve even after months of ATT.
Depending on what we find when we enter the abdomen, the surgical options vary. If the bowel is completely wrecked, an ileocecal resection removes the diseased part and reattaches the healthy ends. If we're just dealing with a tight stricture, a strictureplasty can widen it without losing any actual bowel length. And for straightforward obstructions, sometimes we just need to cut away the scar tissue, known as adhesiolysis. But remember, that golden rule, surgery is just an adjunct. It must absolutely be bookended with continuous antitubercular therapy.
We've seen how this bacteria can perfectly mimic other chronic diseases, hiding behind vague symptoms and ambiguous masses. It really leaves you wondering, with such nearly identical clinical presentations, how many patients out there are misdiagnosed with Crohn's disease before the true bacterial culprit is finally uncovered? It just goes to show how vital a perfectly executed biopsy and a razor-sharp clinical eye really are to uncovering the truth hidden inside the gut. Keep asking those hard questions, keep looking past the surface, and thanks for joining me for this explainer.